I do put a lot of emphasis on creating connections between people with and without psychosis, because I believe that, first of all, I believe that psychosis exists on a continuum and that many people experience psychosis or psychosis-like experiences throughout their lives. And by highlighting that, I think it highlights that there's connections, and by recognizing these connections, we could have the potential anyway to create a less stigmatizing community whereby people get the help that they need when they need it. But the argument's a little bit harder to make with schizophrenia and psychosis, um, especially among lay people, but even among people that have mental health training. People will always say to me, Dr. Schiffman, I understand depression. I get sad, blue, depressed, whatever. Stuff happens. I get kind of down. I understand anxiety. I know what it feels like to be nervous or, raise my hand in class. I get all anxious or, peak five, the last one I'm going to mention is communication difficulties. Do people tell you that they can't understand you? Any problems with communication, like vague, confused, muddled, racing, or slow speech, difficulty staying on track? Do you ever completely lose your train of thought or speech, like suddenly blanking out? These are the kinds of probes that get at communication difficulty. The SIPS covers negative symptoms as well. I'm not going to spend as much time on negative symptoms, but some of the example questions, do you have any close friends? Do you engage in social activities? Do you find that you have trouble getting motivated to do things? Has anyone pointed out that you're less emotional or connected than you used to be? Are you feeling emotionally flat or having a hard time distinguishing different emotions? These are some of the negative symptoms. I have alluded to the distinction between risk versus full threshold psychosis being around insight. So I just wanted to share a couple more thoughts about that. Intensity and severity play a role in this too. So if symptoms are very intense and very severe, for that at least. So part of this, I think, is the state of the problems are is in part driven by the fact that violence is a hard concept to study, especially with psychosis. But things like who do you ask? Or do you talk directly to the client, to the family members, or do you just look at paper trails like arrest records? You're going to get different information depending on the source of your information. Who do you follow? Clients with psychosis or schizophrenia living in with their families in the communities, clients in jails, hospitals, men, women, both. Folks that are living, there could be biases in samples depending on where people are, depending on how they were picked up, brought into the system. What is your definition of psychosis? Does it have to be like research defined, like a skid interview, diagnosis of schizophrenia, or hospital records? What about how broadly is your study? We were interested. The name of my clinic is called the Strive for Wellness Clinic, and my clinic in Maryland. But we were struggling with the idea that we don't really have a well-established evidence base to work with people at risk for psychosis. So what do? First we sort of see what's out there, and one of the things that's pretty clear in the literature is that antipsychotic medications, the pros and cons are important to consider, and the cons outweigh the pros of giving antipsychotics to a person at risk for psychosis. So antipsychotics not recommended at this stage, leaving us with this question: how can we create a client-driven, which is part and parcel of our values, that's also scientifically supported approach to care? We thought modules would be a good way to do this. Now, what is a module? A module is like a self-contained unit of intervention that can be used. And I'll give you some examples. It'll make sense.